are bringing to us and have brought to us, as the title of this session is, biosimilars in supportive care, because that's where in oncology they all started. So the subtitle's point of view of international, so I'm the international one, and Russian experts you will soon have another perspective. So I put that from international down to European. I will show to you that there are some modest but significant differences between the approach of the United States Food and Drug Administration and the European Authority, the European Medicines Authority, in determining biosimilars. Actually, the regulatory pathway to determine that a drug can be called a biosimilar was started in Europe, and for many reasons it took a long time for the Americans to adapt. So in some ways we can say that Europe has been a pioneer and the rest of the world is following. So what is, according to EMA, a biosimilar? The first point is that, not on the slide, but you should not confuse. We have two different ways of looking at drugs. From the original drug to the one that is then made years after by a company when the patent has expired. And we have the simple drugs, which are simple chemicals, and those new ones which are the same as the original are called generics. And many of you know that there have been and there continue to be discussions about, can I really substitute the patient that is on original drug with a generic, simple compound. And then we have our new molecules, much more complex, which are biologics. And that's where we have biosimilars. Biosimilars means that we can never have exactly the same. But I will explain to you that in my perspective and the perspective of the authorities, this doesn't matter. So the definition here is that a biosimilar is a biological medicinal product that contains a version of the active substance of an original biological medicinal product, which is called a reference product, in the European Economic Area. Why European Economic Area? As you probably know, one of the largest producers of drugs in the world is Switzerland. Switzerland is not part of the European Union, but there's a treaty between Switzerland and the European Union which is enlarging this to the European Economic Area. And then there are some regulatory pathways that are called here comprehensive comparability exercise that lead to the acceptance of a drug looking at the reference product as a biosimilar. This is very important because in the whole world there are drugs that call themselves biosimilars, but have never demonstrated that they actually are as good as the reference product. And this can create problems, and has created problems in many countries. There are some slight differences, as I said, between the European and the approach of the United States. And whether we like it or not, in many countries in the world, FDA remains as the example to follow. So one of the points that the European authority has not been dealing with is the so-called interchangeability. It is not because there is no science behind it. It is because health laws in Europe are national. And the countries asked that the fact that you can change from one product to another, or if the doctor prescribes, there can be an automatic substitution by the pharmacist, is something that has to be discussed by the national law and not by the European law. Of course, in the United States, it's different. And that is why they have a different approach, and they have asked for studies where you can demonstrate that indeed you can go from original to the biosimilar and back if needed. But even in the United States, some states still say, we want to have power to decide whether this is accepted or not. For the pharmacists in the room, for the clinicians, I believe this makes no sense. Because if a drug is a biosimilar, it is the same product. So why are we saying that we cannot give one or the other if we accept that they are the same? But regulatory people are regulatory people, and they want to complicate everyone's life. The impact of the advent of biosimilars in oncology and in other areas of medicine, like inflammatory bowel disease and some rheumatic diseases, has been enormous. You have here a slide that shows you here that, for example, one drug used in inflammatory bowel disease, infliximab, has reduced the costs. The discount in some countries has been, as you can read, up to 70%. So suddenly there is more money in the health budget for other drugs. And you know in oncology that we are facing throughout the world the difficulty that new, very efficacious drugs are coming, but at the cost, and we need to find the money. And the development of biosimilars will help us also with improvement of our health systems to find the money for those drugs. Nevertheless, there are discussions. As I alluded at the beginning, the older among us remember the times of the generics and the debates, can I use a generic? When we went from Taxol from Bristol Myers to the generic paclitaxel, everyone said, do those companies that produce the generic paclitaxel really know how to produce the drug? Of course they do know. But there can be subtle differences, not in the active substance, but in the way the substance is delivered, and that has created problems with many generics. Some of you might know that in France, 2 years ago, the thyroid hormone thyroxine produced by one company was changed. The company decided to use another production system. They did not change the name. And suddenly patients started to complain about some problems. This became a big, big thing in France and started to spread to Europe because it was also happening in other countries. It is a few patients that had a problem, but it was enough to create a psychosis again about generics. And this is then coming to biosimilars, because everyone says, if with generics we have a problem, what about biosimilars? Yet we have, in oncology, now for many years, used biosimilar GCSF, biosimilar short-acting filgrastim. We have been using different epoetins, biosimilars. And the only problem we ever had with these drugs was actually the originator epoetin, never with the biosimilar. So last year, there was an important paper in the Journal of the European Society of Medical Oncology called Annals of Oncology that showed for one GCSF biosimilar that indeed switching between the original and the biosimilar was perfectly safe. This was a study that was done on the request of the FDA. And I was asked to write an editorial about that drug and specifically biosimilars. And I gave the title to my editorial, Biosimilars in Oncology, Much Ado About Nothing. Some of you might know about the play of Shakespeare that inspired this title. All the noise we are making, or some people are making about biosimilars, is understandable, but it is not scientifically justified. Either we trust the European Medicines Authority or the FDA or similar organs in Russia, or we don't. And if we don't, why do we trust them for the original products? That's the same question. So of course there are some key questions. The key questions are, this company that is producing this biosimilar, is it doing the right job? Do they have the technology? And there was, and if you go to the website of FDA and EMA, there were many examples where the authorities stopped a biosimilar saying, we are uncertain. demonstrating that they are paying attention to this question. But at the end, we have to realize, and if there is one message you should keep in the back of your minds, it is that a biosimilar or the original product are actually modified every year. You have to understand that what is the original product today is different from the original product of many years ago. The GCSF of the original company is not the same because, of course, the factory that is producing is changing, is modifying its techniques. The machines are changing. The cells from which these products are extracted are living organisms. So the authorities require constant reporting of the even slightest manufacturing change. Some of them are accepted by everyone as not important, but some are critical. And if you go to the website of FDA and EMA, you will realize that trastuzumab, rituximab, which are the new biosimilars in oncology, have been changed over the past few years. So this whole debate about biosimilars being maybe not as good as the originals because they are not produced with the same plant is not scientific. Of course there is a question, because we need to know, and this is in many European countries the law, what exactly the patient is receiving. But it is not about the biosimilar, it's about any drug. You know that there can be problems. I alluded earlier to the fact that a long time ago there was a minimal change in the production process of epoetin, which then led to pure red cell aplasia because of an immune reaction. This was an original product. And there we learned that it was very important to know what exact batch of drug was used for the patient, and we were able to identify that the problems were related to batches produced in one factory